Welcome to the floor, everybody. I am so glad you're here with us today. Look, we are about to make the single most important shift of your entire career. We're transitioning from being textbook-focused nursing students to active, quick-thinking clinical practitioners. In this explainer, we're going to unpack the absolute foundations of adult learning using the Kolb experiential learning model. Really, I want you to think of this as your psychological toolkit for thriving on the ward.
So, let's just dive right into it. How exactly do you make that massive leap from a student to an expert? Because let me tell you, it definitely doesn't happen by just passively reading another textbook or sitting in the back of another lecture hall. Adult learning, especially in a crazy, high-stakes clinical environment, is an active, messy, and continuous process. You're no longer just receiving information, you are officially in the driver's seat. To become a true expert, you've got to actively engage with your environment every single shift.
Well, that brings us to a really foundational quote from management expert David Kolb, published way back in 1984. He states, "Knowledge results from the combination of grasping experience and transforming it." I really want you to let that sink in for a second. Your patient care doesn't magically improve just because you happen to stand there and witness something happen. It improves when you literally grab hold of that hands-on experience and mentally transform it into a new skill or, a deeper understanding. You have to process the raw data of your shift at a much, much deeper level.
All right, moving to section 1, the experiential cycle and its 4 stages of learning.
So how do we actually process all that raw data? Notice how Kolb's continuous 4-stage cycle maps perfectly onto your daily nursing tasks. Step 1 is concrete experience. This is all about feeling and active involvement. It's comforting a distressed patient or literally feeling the physical resistance of a syringe. Step 2 is reflective observation, which is watching. This is when you step back and observe a senior nurse handling a really complex code, looking for the deeper meaning in how they communicate. Step 3 is abstract conceptualization, or thinking. This involves logical analysis, sitting at the chart, looking at lab values, and truly understanding the pathophysiology of what's happening in front of you. And finally, step 4 is active experimentation, which is doing. You're testing out your knowledge by actually adjusting the care plan or initiating a new intervention. Now, you can jump into this cycle at any point depending on the situation, but the absolute best clinical learning happens when you intentionally practice all 4 of these modes.
Let's move on to section 2, dimensions of care, specifically perception and processing.
Let's look a little deeper here. Underlying those 4 stages we just talked about are 2 major dimensions that completely dictate how we interact with our environment. First up is perception. Basically, how do you take information in? On one side of the spectrum, we have concrete experience. Nurses who lean this way perceive situations through profound empathy, sensitivity to others, and direct feeling. They read the room. On the completely opposite side, we have abstract conceptualization. These nurses rely on strict logic, systematic approaches, and ideas rather than feelings to deal with a patient's problem. Now, neither of these is wrong, but recognizing whether you naturally lead with your heart or your head is the very first step to expanding your clinical toolkit.
Okay, so next up is the processing dimension. Once you perceive the information, what do you actually do with it? Well, some of you will naturally gravitate toward reflective observation. You process things by objectively watching, listening, and carefully judging before you form an opinion. You really want to see all the perspectives first. But others process through active experimentation. You want to dive right in, take calculated risks, and physically experiment. You're the kind of nurse who figures things out by actually pushing the buttons on the new IV pump instead of reading the manual first. You just want to get things done.
Which brings us to section 3, discovering your nursing style. When we combine how you perceive and process things, we can actually map out your specific learning style. And guys, this is absolutely vital for understanding yourself and your colleagues on the ward. We've got 3 of the 4 main styles broken down right here. First, a diverger combines feeling and watching. They are incredibly innovative, imaginative, and highly people-oriented. They're the ones who are great at facilitating nursing support groups. Then we have the assimilator, who combines thinking and watching. They pull a bunch of different observations into an integrated whole to create theoretical models. These are very often your clinical researchers. And then you've got the accommodator. They combine doing and feeling. They are highly adaptable, intuitive problem solvers who just love discovery learning and trial and error. They usually make excellent clinical educators. But honestly, here's the style I really want to highlight for us today, the converger. They combine abstract conceptualization and active experimentation. Simply put, they think and they do. This is the classic nurse and engineer archetype.
Convergers emphasize the practical application of ideas. They excel at making rapid decisions, solving urgent problems, and dealing with the intensely practical, gritty work of keeping patients alive and healing them. When the alarms are sounding on the floor, you absolutely want to channel your inner converger.
Now, while Kolb is all about experience, I do want to briefly mention another framework you're definitely going to encounter, and that's the VARC model. This focuses strictly on the sensory pathways that information takes to enter your brain. Are you a visual learner who needs to see the anatomy chart? An oral learner who gets the most out of listening to the handoff report? A read-write learner who just devours the policy manuals? Or maybe you're a kinesthetic learner who literally needs to touch the equipment to really understand it. Figuring out your VARC preference can be a huge help when you tailor how you study your continuing education modules.
All right, Section 4, Applying the Model, Solving Real Clinical Problems.
Let's see how this actually plays out in our day-to-day practice, right? Because theory is pretty much useless unless it solves real clinical problems. Here is a very real, high-stakes scenario you are going to face constantly. A nosocomial, or hospital-acquired, urinary infection in a patient with an indwelling catheter. How do we prevent this? We're not just going to guess here, we're going to use the experiential cycle to problem solve.
So if we channel that inner converger archetype and apply Kolb's model, we can systematically break this down. First, we clearly define the goal, preventing the infection. Next, we pull from our abstract conceptualization. We think back and recall the established rules, the strict sterile technique principles we learned in lab. Then we analyze the specific clinical situation right in front of us. Why is this particular patient at risk? What are the specific causes in their unique environment? And finally, we move right into active experimentation. We actively test solutions. Maybe that's implementing a brand new hygiene protocol or strongly advocating for early catheter removal to prevent those infections in the future. Boom, we complete the cycle.
As we wrap up this explainer today, I want to leave you with a super powerful mantra from our source material. What I hear, I forget. What I see, I remember. What I do, I know. As you step out onto the floor today, remember that true clinical mastery isn't just handed to you, it is earned through action. You literally have to do the work. You have to feel, watch, think, and most importantly, do. So I'm going to leave you with this question. On your next shift, are you just going to try and survive the hours? Or are you going to intentionally transform every single experience into clinical expertise?